It's a pleasure to introduce to you Professor Joseph Califano. Joe is, I think, one of the very few and most established researchers in head and neck cancer. He's not only a very successful researcher there with multiple R01 NIH grants and wrote over 200 papers on the field. He's also a model for surgeon scientists. Joe was trained, had his MD degree at Harvard, and he did his residency at Johns Hopkins University, went for a year or a couple of years to Memorial Sloan Kettering for fellowship, and went back and was many years at Johns Hopkins, where he did both excellently in research, basic science research, and in clinical curing head and neck patients. Joe is the editor of Oral Oncology and associate editor of Annal of Surgical Oncology. And recently he moved to UCSD, and he's now the head of the head and neck cancer at UCSD. It's a pleasure, Joe, to have you with us. And Joe's going to speak about treatment of oropharyngeal cancer in the HPV era. Thank you.
Thank you, Ziv, and thank you to everybody at Rambam. I spent the day today talking and interacting with many people, and it was really a pleasure. This is my first trip to Israel, and it's been absolutely wonderful. And I really thank Ziv for the opportunity, and thank you for the opportunity to be here. So today I'm going to talk a little bit about treating oropharynx cancer in the HPV era. And certainly in the United States, this has really changed oropharynx cancer for us dramatically, and we still haven't finished this dramatic change. I think the next wave, as you pointed out, will be immunotherapy. That's going to dramatically change. I think we've only started to see the first responding trials. It wouldn't surprise me if really this immunotherapy became first-line therapy for metastatic disease, very shortly within the year. The next question is, what do we do for non-metastatic, non-recurrent metastatic disease with immunotherapy? And that's going to be very fascinating. But be that as it may, we'll talk about oropharynx cancer, and I'll talk a little bit about clinical presentation, staging, treatment, and then I think a little bit, a few new things in terms of surveillance and survivorship, which are really becoming key issues. In head and neck cancer, when everybody dies of disease, or over half the people die of disease, you worry about cure. But in HPV or oropharynx cancer, because most everybody will live from their disease, we start to think about survivorship and what that means. So we'll talk about that. So obviously, mostly we talk about cancer being smoking-related, and certainly in Israel, oropharynx cancer is predominantly a smoking-related phenomenon. But in the United States and in Western Europe, Canada, and other North American sites, really, HPV virus is the prime reason a patient presents with an oropharynx cancer. And we think that these are easy to cure, but people still do die of the disease, and there's a lot of treatment-related effects and morbidity associated. And our treatment in this disease is really evolving. That being said, we still see some, in our population, the United States population, first we see historical data that showed odds ratios for smoking and drinking really quite high, of upwards of odd ratios of 7.4 when combined smoking and drinking, very high odds ratios for oropharynx cancer. Recently, though, in the modern era, we actually see decreased odds ratios. This obviously is not due to decreased risk associated with smoking and ethanol exposure. This is a dilutional effect with the dramatic influx of non-smoking patients who actually have HPV-related oropharynx cancer. So we know this is a very standard clinical profile. In general, they tend to have smaller primary tumors, but advanced nodal disease. Performance status is usually excellent, and they tend to be less than 20-pack year smoking history, male, Caucasian, slightly younger, maybe, can be as early as 40 to 50 years old. I see 1 or 2 of these patients a week now presenting to my clinic. It's a very classic story, and we see an enormous and ever-increasing volume. I do have to really talk about this as a citation that's really the most current looking at the rate of this disease in Israel. And see, it's really a minority of oropharynx cancer patients have HPV-positive disease, but still the same characteristics. Younger, tend to have nodal metastasis, tend to be never smokers. So the biology is likely very similar. What probably my guess from these data are, and Ziv actually pointed this out in the article, is you're looking at different exposures. And I don't spend too much time talking about exposures, but basically the concept that's really operative, it's orogenital sex likely is associated with HPV viral integration or HPV virus infection early in life. I should note that even though we know that this is probably associated with development of the disease, there are plenty of patients who do not have this exposure who still get oropharynx cancer related to HPV, likely due to other factors. And we hypothesize these are host factors, but we're really not sure. There's some behavioral associations, but they're not universally true for all patients. And there's a whole other hour-long talk about how we counsel patients about exposures, how we counsel their husbands and wives and partners, and how we understand what the impact of this is for people's relationships. And basically the one thing I will tell you as an aside, that patients are not infectious. The exposure usually predates disease development by up to 3 decades or even more. And this does not imply promiscuity. It does not imply infidelity. It's important to let patients know that. So this is where we were in 2010. This is a famous inflection point for us where this is about the time the amount of oropharynx cancers in men was identical to the number of oropharynx cancers in women. And right now in the United States, we have more oropharynx cancers related to HPV than we do have cervical cancer, which is really kind of fascinating because cervical cancer really occupies a really significant success story in terms of prevention using pap smears and other technology to detect early preclinical disease. And we really have a real challenge on our hands to detect this disease for us in a preclinical fashion. We don't have those technologies at the moment. We expect that this number may double again between 2010 and 2030. In the United States, attempts at immunization in young children have really been largely unsuccessful due to political, systemic, and cultural issues. Whereas in the United Kingdom and in Australia, for example, immunization rates are extraordinarily high. We have really failed as a society in the United States to provide adequate immunization. And the disease burden that's going to result from this will play out over decades and decades, well beyond the time when I retire from practice. So, as we all know, HPV-related oropharynx cancer has a very favorable prognosis associated with it. These are classic data from the Qianang paper looking at the RTOG trial data showing overall survival really significantly improved in favorable prognosis HPV-positive patients. It's even higher in HPV-positive never smokers, can be over 90% in limited series. Some people quote even overall survival of 100%, which is usually due to small series in single institutions. But be that as it may, it can have a very favorable prognosis. Whereas smoking-related cancers that tend to be HPV negative can really have a really dismal prognosis and associated with them. We'll talk a little bit about the biology. So failure pattern is actually kind of interesting. There's been a lot of debate about failure pattern, and some investigators, particularly at Princess Margaret, I know Brian O'Sullivan has published data from that single institution that there's vastly different failure patterns between HPV positive and HPV negative. When you go ahead and look at these data from Qianang, you see actually the failure pattern in terms of local regional relapse, distant metastasis, is actually very similar between HPV positive and HPV negative. And the reason why we tend to like these data better is because they're multi-institutional data, they're not single institution, and they're gathered prospectively. And you really don't see much difference other than survival. The differences between the distribution is quite the same. So We know these have different biology, these HPV positive and HPV negative diseases, different prognosis, different patients. It really are different diseases. So theoretically, we would treat them differently. Well, the answer is no, we don't treat them differently. Currently, we don't treat them differently currently. Well, maybe a little bit differently, okay? We don't have great prospective level 1 data to treat them differently, but in our practices, I see smiles in the audience because I know that people who are actually treating these diseases know that there is an intrinsic bias that is already influencing our care. Even though we don't have great level 1 data, we tend to probably do treat these patients a little bit differently based on some indirect data, and so we'll talk about those indirect data. So the first thing to say is that regardless of whether it's HPV positive or HPV negative, a multidisciplinary team approach is appropriate. And when I was training, we heard a lot about the multidisciplinary team approach, how it was better, much better. And honestly, there were no data, but now we actually have some pretty good data coming out of even internationally in Taiwan, and some data in MD Anderson looking at tumor board recommendations that when patients are treated in a multidisciplinary team with a formal tumor board to provide recommendations, and ancillary staff that provide supportive care in addition to physician staff as a team, overall survival is significantly improved. And this has become well demonstrated, particularly in head and neck. As you know, head and neck cancer is a disease that has different treatment modalities, requires constant collaboration between different physicians and speech-language pathologists, nursing, nutrition, and the like. So it's important to notice that really for us now as a standard of care for these patients, we really want a multidisciplinary team. And this, I'm sure in Israel as in the United States, this is a challenge. Not every patient has immediate access to a tertiary academic center where you can easily obtain multidisciplinary care. But really part of our challenge for this disease is to provide that environment for our patients, regardless of where they come from, either by referral, by close collaboration, by collaboration using electronic medical technology so we can do therapy at a distance, but to provide multidisciplinary care for these patients as best we can, because we will actually have better survival. I talked about the fact that we really are no longer physician teams anymore, we're multidisciplinary teams. And really all these people, particularly I do want to say that social work, palliative care, pain service, in addition to our traditional leaders, as well as, I should add, dental and oral maxillofacial medicine are really very key in this. So let's talk about therapy. Very straightforwardly, we can talk about early stage disease and late stage disease. Now, I will tell you that later on in the talk, I'm going to give you the draft version of the new AJCC-UICC staging system for HPV positive oropharynx cancer. Okay, it's still in the draft phase. It's almost finished. There's still some issues with nodal staging that probably are being discussed as we speak, as I see on emails. But you'll see that we no longer are going to use this. But for convention right now, I'm going to use the conventional existing 7th edition staging. So for early stage disease, really we just want to have single modality therapy. It's simpler, easier, less cost, and every bit as effective. Multimodality therapy does not tend to give improved outcomes. So it's either radiotherapy, primary excision with usually a staging neck dissection, and if we do primary excision, or whether we do staging or radiotherapy based on the laterality of the primary tumor, where if we have lateral tonsil cancers, we tend to just treat the ipsilateral neck or stage the ipsilateral neck if necessary, and if we have base of tongue or central tumors, certainly bilateral, either staging or prophylactic radiation would be more appropriate. So for late stage disease, it gets a little bit more complicated. Certainly primary excision plus minus neck dissection or with postoperative radiotherapy and concurrent cisplatin for extracapsular spread or positive margins would be appropriate. I think that really is still the standard of care in the United States, certainly in most places, based on data from Bernier and Cooper from New England Journal article in 2004. There are some data that challenge that, certainly. The group in the Mayo Clinic certainly has data that suggests that extracapsular spread is really not as important a prognostic indicator in HPV positive oropharynx cancer when treated with upfront transoral robotic therapy. Although I think that may have some merit, there are other studies that suggest it may have some attenuated effect, but for right now, I think this still remains our standard until we have more definitive data. Certainly concurrent chemotherapy and radiation is acceptable and gives excellent cure rates as well. Usually, I think a standard for us is still cisplatin in patients who can tolerate cisplatin. Cetuximab may be an appropriate alternative second-line therapy, but really cisplatin, I think, is probably the gold therapy. I always put this here, induction chemotherapy and radiation with radiation with concurrent chemotherapy is an alternative standard of care, certainly in Europe. To be very blunt and honest, I do feel like this is really over-treatment for these patients. We do still see it sometimes, and certainly in Europe, I think in some centers this is what people use as standard of care. But I think really this really is kind of our de facto standard, certainly in North America. But in Europe, perhaps they use it a little bit more. And why? Because these patients tend to do well regardless. It's a little something I have to do here. I apparently have to buy a license for this right now, but hold on one second. Can you clear that for me? It's, yeah, I guess it's because the, okay, I think we're good. Yep. So I'm going to show you the draft new staging system, and the tumor I think will not change. Fairly straightforward, really not much different than we talked about with T3s extending to the lingual surface of epiglottis as a T3, and really the same discussion about moderately advanced local disease. I will tell you that similarly, the mucosal extension to lingual surface of epiglottis from base to tongue does not constitute larynx invasion. Very straightforward. Here's where it gets interesting. This is being divided into a clinical and a pathologic nodal staging. Whereas beforehand it was unified clinical and pathologic, now clinical is really just one or more ipsilateral lymph nodes less than 6 centimeters is N1, contralateral bilateral all less than 6 centimeters, and anything greater than 6 centimeters is N3. Different nodal staging right now than what we're used to. And for nodal staging criteria here, for pathologic nodal staging, there's no size criteria anymore. And limited to just number of lymph nodes, not based on extracapsular spread, which is going to be different than the nodal staging in any other site HPV negative in AJCC 8th edition. So a unique nodal staging, both clinically and pathologically. And it's a little hard to do this, but if you mentally remember what these are, the overall staging is going to be a little bit different as well. So overall stage, you'll see this is really radically different than what we're used to, where basically the only thing you can have up to N2 disease, which is really quite large disease, and you still maintain, this is clinically, still maintain overall stage 2. So you can have T3, N2 disease, you're still staged overall stage 2. And this is to reflect the fact that these data, by the way, are based on data from Washington University, Princess Margaret in Toronto, and several other institutions, including Memorial Sloan Kettering, that have large single institution data sets. I will tell you that this staging is definitely more appropriate than what we've been using for all oropharynx disease, but I am sure it will garner tons of criticism. I'm absolutely sure that this staging system is going to change for the 9th edition. And why is that? Because the way in which staging occurs in AJCC is not just through literature-based publication, but through analysis of SEER and NCCN databases that allow us to look at data that have been developed during the prior years that have been enrolled in by registrars with these criteria, and analysis of a very large number of patients within the United States system. So what's really driving this is stage separation of Kaplan-Meier curves. The greater the separation of Kaplan-Meier curves, the more appropriate the staging system. That's kind of the general philosophy of the AJCC. So this, at least in these large data sets, is what gives best separation in terms of disease-free survival and overall survival. So again, to move on, when we look at what makes overall stage 3, it's really getting N3 disease or T4 disease. It's interesting, as you know, so T4 no longer gives you stage 4, it'll actually give you stage 3, and only distant metastatic disease really is classified as stage 4 disease. Similarly, for pathologic staging, remember we're now moving that slightly different pathologic nodal criteria where it's just number of lymph nodes now being used. And essentially, if you have more than 4 lymph nodes and you're just T0 or T1 or T2, you're still stage 1. You basically need to, less than 4 lymph nodes. Anytime you get to be more than 4 lymph nodes, you just go to stage 2. And the only thing that really brings you up to stage 3 is basically if you have T3 or T4 disease and N2 disease more than 4 lymph nodes. Otherwise, again, only distant metastatic spread really brings you to stage 4. So a radically different staging system, different from any other site, really creating a kind of a unique system for this disease. So let's go a little bit to therapy. We're going to talk about surgical advances. Really the big change now is transoral surgical. So smoking history is not in the staging system right now. And that's a really good question because we know from trial data there is prognostic significance. So the question is smoking part of the staging system? And this is the current draft, and that's why I say it's the draft still currently. A couple things happened. As you know, the recursive partitioning analysis from the Kianang trial was published, looked at 10 pack years as a cutoff for smoking. From multiple data sets, it's clear that probably that's a little low, that maybe the adverse effect of smoking really kicks in 20 pack years. However, the issue, the reason why, there's 2 reasons probably why smoking didn't make it into the staging system, okay? The first is that its effect is not that great independently when you take into account this staging. So realize that there's some effect where smokers tend to have slightly more advanced stages anyway. So some of the independent contribution of smoking to staging or prognosis is attenuated by the new staging system. So when you have an appropriate staging system, smoking has less contribution. That's the first thing. The second reason is a little more subtle. When you're trying to define prognostic factors for within the AJCC system, it's not UICC, but AJCC system, the AJCC as a group likes to see that those data are collected prospectively by registrars within member institutions that report out these large Kaplan-Meier data sets you see in the AJCC's handbook. Historically, there's been real challenges in getting appropriate smoking exposure data enrolled by registrars. So the problem is that when you're trying to validate a staging system with prior data collected over the previous period, the smoking data are not there. So that's probably the second reason why smoking data are not there. And having been on the AJCC committee now for 2 editions, I can tell you that, I love prognostic factors. We pushed really hard to get HPV in situ and P16 immunohistochemistry in the run-up to the prior 7th edition, and it's really probably only in the last iteration that we've actually been able to do that. So there is a significant lag time between what we know biologically and what gets enrolled and incorporated into registrar systems that we can act on in staging. So it's probably not 1 edition, but probably 2 editions worth it takes until you get to that point. And even for lung cancer, for example, the smoking history has been very, very poor compliance. So it's very hard to get that data, those data. So we'll talk about transoral resection. Again, we're going back to the old staging system here. It's primarily directed at low T-stage disease and then N0 to N2A or even N2B disease. There's no question that we'll talk about this improved function compared to transcervical approachers. It's not whether you use a robot or a laser. It's just that you resect the primary tumor with appropriate margins through a transoral approach that makes the difference for this technique. It's about adequate margins and transoral approach. And actually the utility for this is not just as curative therapy, but also for staging, certainly as a way to de-intensify therapy and certainly for salvage therapy. So this is the original Weinstein paper where the rationale for this technique was presented as de-intensification, where 10% of patients didn't have any radiotherapy, half of them had radiotherapy alone. So you're able to avoid concurrent chemotherapy in half the patients. And this was actually somewhat controversial when when presented. So there are more data since then, but there are some caveats we have to talk about with transoral resection. One is that there's retrospective data, and there's probably significant selection bias. We choose patients who we know are going to be good surgical candidates, or if we're smart as surgeons, we will do that. You know, we're not always the smartest, but generally when we choose appropriate candidates, we are shunting certain patients that would not do well with surgery into non-surgical therapies. So that is a clear selection bias. But that being said, the data are actually pretty impressive. This is an early, the first really good functional outcomes paper. It looked only at a limited amount of 42 patients, but really didn't find any long-term G-tube use, some prolongation when people had chemotherapy. But basically patients really recovered their swallowing function. So really patients do very well. Again, this is 2012 out of the Mayo, larger, but really spectacular survival, but also really fairly low long-term G-tube use, and most patients really taking PO 3 weeks post-op. In the modern era, we really are feeding patients 2 days post-op. I personally have not had a patient who could not eat within 2 to 3 days going home on solely oral intake after 3 or 4 days. You just don't see that. Partly because we're a little bit more aggressive about feeding patients. As you do this procedure, you get a little bit more perceptive and thoughtful about who's going to be a good candidate for transoral resection, and our expectations to aggressively rehabilitate these patients is better. So really good swallowing functions. One of the more interesting studies is that when looking at salvage approaches, where there's a matched pair analysis, retrospective, TORS versus an open approach, really transoral resection for salvage patients did better. Shorter surgeries, fewer positive margins, which is very, very important because that's really the measure of our surgical efficacy. And recurrence-free survival was actually higher. Again, these are matched pair, match for stage, match for initial therapy. Some way in which we can address bias, some selection bias for transoral resection, but really, certainly in my practice, if I can do a transoral resection for salvage, I will definitely preferentially do it as well. You know, there's some thought that maybe this is a way to do treatment intensification, that rather than avoiding radiotherapy, we can intensify therapy. So for example, this was initially reported out of Penn in 2013, very small series, but didn't find any difference between HPV positive and HPV negative groups. It's a small sample size. Recently, this is a larger cohort of multiple groups, including some of the data presented previously, looking at a large cohort of patients retrospectively, basically finding similar things, that about 30% of the patients had post-op radiotherapy, 21% chemoradiotherapy, and the rest really were able to avoid either non-surgical therapy with excellent disease-free survival and overall survival at 2 years. The interesting thing about this analysis is that, so by the way, HPV status was not able to be defined in this cohort, so I actually called the senior author, who's Chris Holsinger. He said undoubtedly most of these patients, probably 80–90% of them are HPV positive, but they were unable to get that data, so they did not include it in their multivariate, which is one key flaw with this study. But interestingly enough, age, tobacco, and tumor stage were actually not significant on multivariate analysis. So the implication is that there's a potential use for a surgical therapy where we may be able to address some of the poor prognostic associations associated with surrogate markers for HPV status, which would be tobacco use in these patients. This is, again, a very recent study that would actually specifically address HPV and smoking and transoral resection outcomes. Here, in contrast to this previous study where you didn't see much effect on smoking, here in a slightly smaller cohort, you actually do tend to see some effects. So here, HPV negative smoking patients have poor local regional control, poor progression-free survival as compared to HPV positive non-smoking patients. We really have just excellent survival. Again, small number, surgically selected, but still you can see this effect. So the answer is still out, really, whether or not patients who are HPV negative smokers will actually benefit from treatment intensification with upfront surgical resection. I think the answer is I think when I talked about how we actually do treat these patients differently, I think HPV negative smokers, we probably do actually treat more aggressively with surgical therapy, and certainly in both my current institution and my prior institution at Johns Hopkins, I think we would, if we could resect these patients up front, we would go ahead and do that, and even offer them concurrent radiotherapy with chemotherapy postoperatively if they have any even modest adverse prognostic indicators based on HPV negative status and smoking status. So finally, is this real? I'd say modest effect is probably there, but really we know HPV status really is the dominant prognostic factor. And again, that's probably one of the reasons why in the new staging system we do this. So let's talk about upcoming trials. What are we going to learn in the next 4 to 5 years? Well, there's 3 critical trials that are non-surgical trials. One is RTOG 1016. This is a very large trial, cetuximab versus cisplatin radiotherapy. Well over 70, I think it's targeted over 700 patients, but I believe it's over 800 patients were enrolled in this trial. That has not resulted yet. We'll have the toxicity data. I think will be presented at ASCO, mature toxicity data. But the survival data, we're still anticipating. This is a non-inferiority trial, so it'll be interesting to see whether we can de-escalate with cetuximab, if indeed, I almost want to survey the medical oncologists whether cetuximab really is a de-escalation, because whenever I talk to a medical oncologist, they say, well, cetuximab toxicity is almost every bit as bad as cisplatin toxicity. But nonetheless, that is this object of this trial. HN002 is really a fascinating trial. It's still accruing. It's dose-reduced cisplatin versus accelerated radiotherapy alone. It's really a double-armed de-escalation trial. It's accruing very nicely, and that should actually result. It'll take a couple years. And finally, de-escalate, which is in the UK, is very similar to RTOG 1016, a non-inferiority trial where the endpoints are not just outcome, but also morbidity and long-term toxicities. Again, one of the themes you see with these trials is that we're not just looking at survival, but we're also looking at long-term toxicities, something to keep in mind for later in the presentation. So finally, this is a trial that's near and dear to our hearts as surgeons. This is ECOG 3311. It's a somewhat complex schema, but basically very low-risk HPV-positive patients using the conventional AJCC edition 7 schema, really go to observation alone. Those with positive margins and gross extracapsular spread defined as greater than 1 millimeter outside a node or greater than 5 metastatic nodes go to radiotherapy. By the way, I should note, again, different from the new staging system. So we have a surgical trial now that's based on the 7th edition staging, and we are going to be using 8th edition staging. My guess is by the end of the year. So also going to be an interesting way to kind of get these patients looked at. But really the key thing driving the sample size is looking at this intermediate risk group with clear margins, minimal extracapsular spread, and 2 to 4 metastatic nodes. They're going to either dose de-escalated postoperative radiotherapy at 50 gray versus 60 gray. And this is, again, to look at progression-free survival, local regional recurrence, and functional outcomes, potentially as in a non-inferiority schema. The original cohort was 377. It's raised a little bit. I want to say it's in the low 400s now. The reason for that is there were more patients getting enrolled both in the high risk and particularly in the high risk, but also in the low risk category. Also a few more, but mostly in the high risk category. As understandably, as surgeons, we aggressively want to get our patients on trials. There were perhaps a little too many of these patients being enrolled, so it's powered for this, so the total number had to be increased. But it's accruing quite nicely and should actually be finished accrual within probably about 2 years, certainly within 2 years. We can talk very briefly about treatment failure pattern. I'm going to move along because I know time is going, but basically, remember we said it was similar. Well, people say, well, but the distant metastatic spread can be in these very crazy sites. Well, is that really true? So a couple interesting things to look at when we look at distant metastatic disease in terms of how aggressive we should be. We know that once patients have progressed, okay, this is since progression, HPV positive versus HPV negative, that the likelihood of progression is still higher in HPV negative. This is combined RTOG data from Kian studies. But there are studies talking about really unusual patterns, explosive metastasis going to strange sites. Most of these are single institution studies with very small sample sizes. So this is a trial published by former colleague of mine, Carol Fakhre, she still is a colleague, I guess, because we still collaborate and they're co-investigators on grants, published in JCO. So there's actually quite a large data set looking at RTOG 0129 and 0522. She basically took a look at this question, and she found some interesting things. The first thing is that survival after disease progression, this is after disease progression, was better in P16 positive patients. So we know that patients who are HPV positive, if they recur at baseline, still have better survival. That's interesting in and of itself. The patterns of disease progression, when you look at P16 positive versus P16 negative, really are the same in terms of local, regional, distant, and the combinations are really identical in terms of percentages. And then when we looked at overall survival, the question is, what's associated with improved survival? Well, if you look at certainly P16 status, age, some conventional ones, T-stage enrollment, but interestingly enough, I do want to say, point you to the idea that surgical salvage is actually, people do better independently, and this is univariate analysis. When you look at the Kaplan-Meier, you can see that's the difference between surgical therapy and right here on the left, and non-surgical therapy here on the right. And you look at it in multivariate analysis, what still is happening, you still see P16 status is important. Salvage surgery is also still really, hazard ratio is actually, the effect is not small, right? It's actually pretty good. And then certainly whether you're distantly progressing or not in T-stage, and certainly smoking. So we know that certainly by these criteria, surgical salvage is actually preferable. And this is to look at the actual Kaplan-Meier itself of surgical versus non-surgical treatment. Again, when we looked at some of the other ones, we see them here. So the clinical relevance is that local regional recurrence is more favorable in this disease. HPV is a really independent predictor of good prognosis. And we really want to focus on surgical salvage therapy if we can. I will tell you that some of these data were really validated in a separate cohort that Carol looked at, showing that really the disease site presentation is really not very different as well. So what about after people are cured? Well, when we look at second primaries in oropharyngeal cancer, and we look at our American cohorts, we actually see here we look at a second primary head and neck going that way down in oropharynx. This is done over a period of time from 1975 all the way over into 2008. You can see second primaries in lung go down, second primaries in esophagus go down in oropharynx, and really kind of a uniform phenomenon. Why is this? Well, it really is HPV probably. These are, quote, HPV-like patients who kind of had that phenotype of HPV through SEER data because you don't have the HPV data there. And you see that their risk of second primaries is down. This is a paper by Gan et al. When we look at HPV positive non-smokers, again in large data sets, this is actually a single institution. We look at HPV never smokers versus ever smokers and HPV negative in general. When we look at never smokers, essentially they don't get second primaries. And if you actually look at the data from this paper, the point is these second primaries are things like prostate cancer. They're not traditional second primary cancers. You really don't think these patients have a risk of true second primary head and neck neoplasms the way you think about it for HPV negative data patients. So when we look at our new guidelines for surveillance, these are the most recent NCCN guidelines. There'll be a new version coming out shortly. But really the surveillance schedule is actually extended. We don't actually watch head and neck cancer patients as closely as we thought we had to because there's no real data that close surveillance makes any difference in outcome. And more importantly, when we talk about imaging, we really look at imaging, and there's a recommendation for post-treatment baseline imaging of the primary within 6 months, but further imaging really based on symptoms, not routinely recommended. And then really chest imaging is really based on smoking history. So for our HPV positive non-smokers, in my practice, I do a post-treatment imaging and that's it. Although I've had this discussion today where as a surgeon, I don't need to order imaging because my medical oncology and radiation oncology colleagues will order scans all the time. I never need to order them. But really, we don't have the indications to do so. There's no evidence that it affects outcome. So really, we don't have any differences in surveillance right now for our HPV-positive non-smokers, but the argument really should be that within 2 to 3 years, we don't really see recurrence of these patients if they're cured from initial therapy. So it's unclear really why we even need long-term follow-up for cancer surveillance, because they don't get second primary tumors. And at about the 3-year point, the likelihood of recurrence of their tumor is incredibly low. So is there a way to define better patient risk for recurrence? I'll show you some data that we did. We looked at actually HPV DNA detection in plasma and saliva. This was 93 patients we collected prospectively at pretreatment and 1 to 3 months after completion of therapy, and we simply asked the question, can we detect HPV DNA in their plasma or saliva after therapy? The cohort demographics show that there's a difference in HPV status associated with race, which is well known in the United States, and smoking status, so all things we know. We looked at them also in terms of stage. There was some difference in terms of tumor stage, which also goes along with how we think of HPV as having increased nodal metastasis. When we look at pretreatment association with HPV status and body fluids, we see really high associations, but when we look at the sensitivity and specificity for detecting disease afterwards, we actually found a very high specificity and a reasonable sensitivity. The post-treatment detection actually would predict recurrence. So I'll show you a little bit in the hazard ratios. When we look at a multivariate analysis, looking at HPV DNA association in post-treatment setting with clinical outcome and overall survival, we're looking at hazard ratios in the range of 10 to 25, even to 40, which is really incredible, that if you have plasma or saliva present in your, with HPV DNA after therapy, you're 24 times more likely to recur. And to show you what that looks in terms of Kaplan-Meiers, I'll show you shortly. Those patients that were body fluid positive afterwards for either plasma, saliva, or both, this was their overall recurrence-free survival. So it's really a powerful predictor of who's going to recur. I do want to just go back to this other slide to show you that the lead time was actually significant. We found a lead time really had a mean of over 250 days for both saliva and plasma. So this is an interesting concept. I'm trying to develop this into a multi-institutional trial to see if we can use HPV DNA in a similar manner in which we use EBV DNA in nasopharyngeal carcinoma. It could be a powerful indicator, particularly in this disease where we have a hard time figuring out who's going to recur and who's not going to recur, so we can avoid over-surveilling people and also perhaps have people undergo more intensive therapy. So finally, we're going to talk a little bit about here. It's not enough just to survive. We have to survive well. We just don't, we want our patients not to just get cured of therapy, but actually have a life afterwards. And we know there are a lot of late effects when we treat patients with head and neck cancer, swallowing dysfunction, xerostomia, dental things, osteoarthritis necrosis. There are a lot of things, and let's just talk briefly about them. So this is a great quote. It's from a paper in 2000, okay? This was from the RTOG trial 9003, which looked at different acceleration schemes. And it said, their acute but not late effects are also increased. Now, this is a trial looking at 3-year outcomes. When you look at long-term data, though, and these are data which were published in 2007, you see that long-term grade 3 more toxicities start to accrue not just at really 2, but even up to 3, 4, 5, and even 6 years from time to start of therapy. That these therapies, these multimodality therapies, and by the way, I'm not just picking on the poor radiation oncologists, medical oncologists, our surgical therapies as patients age. For example, we are not positive that doing transoral robotic surgery many years down the road necessarily results in uniform great swallowing function, right? We know, for example, supraglottic laryngectomy patients can do fine for years and all of a sudden have profound aspiration issues. So similarly, though, but for radiation therapy and chemotherapy, we know that a few years out, we really see some significant long-term toxicities. So what are these? Well, carotid atherosclerosis in radiated patients is really pretty significant. We have relative risks almost close to 6. The cumulative risk of stroke is 12% in 15 years. That's actually very high for radiated patients. These are the best data we have published in JCO. So we know that these patients, we can cure patients in a few years, but long-term we have to watch this. So I will tell you that in my practice at 5 years, we get a baseline carotid ultrasound. and do ongoing surveillance with carotid ultrasound, because patients can be treated with stents, and we counsel our patients to be aware of this. Depression really is a significant problem in head and neck cancer patients. Rates can be anywhere from 15 to 20%. As doctors who treat acute disease, we do a very poor job of treating this, identifying it. I'll give you an example. Bill Lydiot, who is in Nebraska in the United States, did a really fascinating study where he looked at depression prophylaxis prophylactically, basically did a randomized double-blind controlled trial of Lexapro versus placebo in non-depressed patients, the patient not depressed at outset, and basically treated them prophylactically during therapy with either Lexapro or nothing, and actually significantly reduced depression, post-treatment depression in their patients. And this is actually particularly strong effect in radiotherapy. And the thought behind this, by the way, is really fascinating to me, that when you get radiotherapy, you get a mask and you're pinned to a table. And it is not unlike torture, okay, where you're undergoing this every day. There's a lot of anxiety associated with it, powerlessness. And this is a physiologic response to this type of stress. Depression is very physiologic. You can actually blunt it if you blunt the dopaminergic pathway. So it's actually a very logical approach. We know that psychosocial interventions, at least by 2013 assessment, don't appear to have much effect, but actually recent trials show that certainly within the 18-month period, the acute period, that psychosocial interventions actually significantly reduce stress, distress in our patients. So finally, just to summarize, this really is a different disease, this entity we're dealing with, HPV-positive oropharynx cancer. And I know that here in Israel, it now occupies about 30% of your disease burden. It's unclear to me how this disease burden is going to change. Certainly in the United States, it's going to increase in frequency. My guess is, although as we go into a modern era, that disease burden was only going to increase until our immunizations take effect. For us, that's not going to happen. Probably here immunization rates are much better, but one would expect that over time you may see more and more of this disease. As I said, transoral resection really is an accepted primary treatment option. These patients have excellent survival, but really we need to focus on morbidity and toxicity and survivorship as key issues, in addition to treating those patients who are really difficult to treat. So there's a lot of things. We talked about a lot of things we didn't talk about. I'm going to leave you with one more image that is, it's now spring in San Diego, and that is the view when I go outside to walk my dogs in the morning. I am much less productive now than I was when I was at Johns Hopkins on the weekends, but it's worth it because we try to be more productive during the week, and I want to thank you all for listening and appreciate your time.